Hi, my name is Brad Kuo. I'm a GI doctor at the Center for Neurointestinal Health, the GI unit at Massachusetts General Hospital, Harvard Medical School in Boston. And today I'll be talking to you about nausea and vomiting with some insights into treatments. As a definition of nausea, people often describe it as an unpleasant, painless sensation that frequently, but not always, occurs before vomiting. Epigastric discomfort with the urge to vomit or changes in the autonomic nervous system, a nervous system that controls various organs in our body that can be characterized as dominated by heavy sympathetic load, which means nerve endings which control the fight or flight symptoms. Now, evolutionarily, nausea is thought to be this early warning body system, but it's evolved to occur frequently when we actually have non-acutely life-threatening events. And nausea, interestingly, is not pain. People can tell the difference between that, but it is frequently associated with that. So you can have nausea without pain and vice versa. And as we all know, nausea frequently occurs after motion sickness. So it's interesting, we often associate nausea and vomiting together, but they actually are distinct events. So vomiting does not require you to be fully aware. It's a reflex that can happen, whereas nausea requires you to be consciously aware to know what's going on around you to give you nausea. So vomiting is a reflex, and nausea requires that conscious perception. A lot of work has been done with vomiting because there's actually animal models to understand that, and so they have mapped out a lot of the circuits in the brain, which are actually not in the top part of the brain, but more in the old part of the brain that is hardwired with reflexes. Whereas nausea actually involves the nerve endings in the body as well as in the top portion of the brain where there's conscious perception and thinking occurring. There are neurotransmitters, which are chemicals that mediate the vomiting, and that's well known in vomiting, but completely not understood in nausea. And this is ultimately because there are animal models for vomiting, but actually, because it requires conscious perception, there are no real animal models for nausea, and so only humans have been a way that you can understand what's going on with nausea in people. Ultimately, that results in that there are multiple medications called antiemetics that are good for vomiting, but they actually don't have as great efficacy in nausea. So this slide sort of shows you that there are different inputs from the heart and in the stomach. These feed through various nerves called cranial nerves, such as the vagus nerve, and as well as sympathetic and parasympathetic activity that eventually hit the vomiting center in the old part of the brain. And these are partly gated by things called the chemoreceptor trigger zone. And these are some of the hormones and neurotransmitters that are involved in that sort of stuff. And these filter through the parts of the old brain and eventually reach the cortex, the thinking part of the brain, where we can establish feelings about it, such as discomfort, whether there's anxiety associated with it, and other sorts of things mediated by these parts of the brain. As we all know, there's the inner ear that if you get motion sickness or you get spin yourself around in rapid circles, that can also cause nausea and motion sickness, and that feeds from the inner ear to this portion of the reflexive area of the old part of the brain. Eventually, these things all go through an area called the nucleus tractus solitarius, which is the main gateway relay center to the brain for all these types of signals. Now, we did some interesting work to try to understand what's going on with nausea because, again, there are no great animal models. And so we were trying to figure out what parts of the brain are actually involved when you get nausea in human beings. And we were lucky to be the first to report taking human people that are motion sickness prone, subjecting them to this visual stimuli of alternating black and white stripes, sort of like what you would see in an amusement park ride, but sitting inside an MRI scanner. And as we started to make them nauseous inside the MRI scanner, not to the point that they were going to puke or vomit, we started to see areas of the brain light up. And these areas, such as the amygdala, putamen, and dorsal pons and locus coeruleus, these are sort of relay areas that are now starting to light up when you're starting to feel nausea coming on. And these are related to awareness centers in the brain, or almost the fight or flight areas in the brain. So it's telling you something is going on that's not right. Then, when you actually do get nausea, other areas light up, such as the ACC, the anterior cingulate cortex, the insula, and the medial insula. And these are areas that start processing the sensation of nausea and telling you that, boy, this does not feel good. I think this is a bad sensation, and I might be feeling some extreme discomfort. And interestingly enough, these are the same areas that light up when you have pain. And so that even though nausea is not pain, we are starting to see this sort of circuitry that occurs in the brain when you get nausea that completely overlap with what is activated in the brain when a person has pain. Two distinct symptoms, but similar overlap of brain activity. This is important meaning because ultimately this might mean that some of the treatments that we have for nausea may not be just purely based on trying to decrease the vomiting, but maybe have overlap with the same medications that we might use for pain to change how the brain perceives the nausea. Because remember, nausea can only happen if you're awake and can perceive that sensation. Another interesting thing that we did was we took people who had chronic nausea, and we noticed over time, if you have chronic nausea, there are literally changes in the way your brain is wired after chronic exposure to nausea. And that also happens with chronic pain. There are changes that occur in your brain to the wiring that occurs when you have chronic pain. And in this case, this particular wiring tract between the front part of the brain, the anterior insula, and then the visual part of the area is altered in terms of some areas of the circuit compared to people that are less susceptible to motion sickness. So ultimately, we have here this pathwork that we've sort of mapped out in the brain that overlaps the pathways that are activated when you have a pain, so that nausea activates similar pathways that pain activates in the brain. And this can occur over time in chronic people, and that these give also feedback eventually to the vagus nerve and the sympathetic and parasympathetic system to different things that you can see in sweating, increased heart rate, stomach activation or function. Now, there are many ways that you can get nausea into the body. You can get it from the periphery, below the brain. There can be mechanical or chemical irritants, like if you eat something bad or something's going on in your body that's not right, that can feed into the brainstem, giving you nausea. There are blood agents that, if you take a medication that may give you nausea, or chemotherapy. Motion sickness through the inner ear can cause nausea, and that feeds into this brainstem, the old part of the brain that eventually processes and relays it to the cerebral cortex, the thinking part of the brain, where with the nausea you can layer things like pain, emotion, and such. So as a result, we have a better understanding of nausea now in human beings, where there's a central nervous system part of the brain that figures out where the nausea, what the nausea sensation is, and attaches to it emotional response to that. In addition, we have nerve endings that course through the body, through the gut, and through other nerve endings such as the heart and lungs, and also the body bloodstream, which tells what's going on with the body. And if there's not something right, it will feed that signal eventually through this peripheral nervous system to the brain to tell you something's going on. Now, these can be modified through the sympathetic and parasympathetic system. This is an autonomic nervous system that sort of steps on the gas or slows things down in the body in response to something that may be going on. But this all leads to the idea that when patients have nausea, it's due to them crossing a certain threshold, where above that threshold they have nausea and below it they do not. But that threshold can be dynamic, and so that in some patients that threshold can be lower, making them more nauseous. In other people, who don't get motion sickness at all, that threshold can be very high. And so ultimately, when we think about how to treat nausea, we can think about how are we going to change the dynamic threshold, either through medications or other sorts of things, to change how we think about that nausogenic stimulus and how the body ultimately will respond to that. And also from what we've learned, the nausea circuitries are similar to the pain circuitries within the brain. And so that gives us further ideas about how we can treat people who have chronic nausea. Now, when we talk about nausea, we oftentimes look at the evaluation. We ask a lot of things about the history. What happened? Did you have anything that occurred in your childhood that may give you increased nausea? A history of eating disorders? Do you get nausea all the time or early in the morning, or does it wake you up from sleep? How well do you sleep? And oftentimes people get nauseous when they have meals or even with the smell of food. So all these can trigger nausea and may have relationships with pain, emotion, or memory. Sometimes sadness can give us nausea. Oftentimes we ask questions about medications because a lot of different medications can give nausea or vomiting. One of the common ones, an antibiotic called erythromycin, actually stimulates the gut, and that can cause nausea. And oftentimes interactions with different drugs, polypharmacy can give nausea. And certainly there are interesting drugs, narcotics and marijuana that can either make nausea worse or marijuana can actually make nausea better. Now, the doctors, because nausea can be caused from so many different things, the doctors usually do a broad search to make sure there's not anything life-threatening, such as checking your blood salts with electrolytes and checking to see about diabetes, thyroid disease, and other sorts of things. Then we try to check the gut with X-rays and with endoscopy to make sure there's no blockage and make sure there's nothing going on in the brain. One of the areas that will interpret the nausea with a CT scan if it's severe or if there's changes or damage to the nerve endings that relay all the signals from the body up to the brain. We may also check the gut motility because sometimes an abnormality in gut motility may cause nausea or indicate there's damage to the nerve endings in the gut, which may precipitate nausea. And certainly things like anxiety and depression can make nausea worse. So this list is a few things that we'd like to rule out for chronic nausea, things like blockage of the guts, irritation or inflammation that can be caused by infection or different types of medications or other sorts of inflammation in other body structures. Certainly, certain medications such as chemotherapy can cause nausea or impaired gut motility, which means how stuff moves from one end to the other in the gut, because if the gut has problems with moving stuff, the nerve endings can be dysfunctional, which can lead to sensory problems such as nausea. And ultimately, there is a criteria for nausea called functional idiopathic nausea. That's when there's bothersome nausea at least several times a week. Now it's associated with vomiting. It has to occur without any abnormalities, structural by endoscopy. It has to be for 3 months, for at least 6 months. And that is really a person that has chronic nausea all the time, and it can overlap with a number of other gut diagnoses. Now, the main classes for treating nausea and vomiting are the antiemetics, drugs that actually reduce vomiting, but to a lesser extent, nausea. And so these are plentiful. There's a lot of different drugs out there, but interestingly enough, they've been well targeted towards decreasing vomiting, but have less been successful for nausea. Prokinetic agents, medications that accelerate gastric emptying, might decrease nausea a little bit, but if you push the gut too hard, it may actually induce nausea. And then this concept of sensory modulators, drugs, now that we understand that there's activation of circuits within the brain that are similar to pain, can we change the threshold within the brain and maybe even within the body of what the threshold will be for a stimulus to induce nausea? And maybe we could increase that threshold in patients where it may have been pushed artificially low, that may have given patients more nauseous symptoms. So some of these medications are listed here. They're fairly common, such as meclizine, promethazine. There are scopolamine patches and other things to push the gut and change some of the nerve endings. Common one is serotonin modulation, ondansetron, and neurokinin, such as apripitant, and certainly marijuana-like medications called cannabinoids. Benzodiazepines help with nausea and with vomiting because by decreasing the awareness of the brain with a benzodiazepine, you can actually decrease the nausea. But a lot of these medications work well with vomiting, but don't work well with nausea. And oftentimes, if you sedate the patient, make them less aware, make them go to sleep, it will reduce the nausea and may even reduce the vomiting. So really, what we learned from some of the brain work is that patients with chronic nausea may have changes to their brain similar to people who have chronic pain. And maybe we can use medications to change that process, such as tricyclic antidepressants. These are medications that are chronically used for pain, but they change the way the brain interprets signals, and as well as changing the way the gut interprets signals. And maybe that can be used to decrease nausea as well. And there are different types of agents, tricyclic antidepressants, anti-epileptic agents such as gabapentin and topiramate, which has less GI side effects, and maybe even some antipsychotics, which affect dopamine and serotonin, like olanzapine, which has also been used for anxiety and depression. Now, nausea obviously affects one's appetite, and so stimulation of meals or meal composition can cause fears of eating and ultimately loss of weight. And so things such as cognitive behavioral therapy can be employed, and we have to be on the lookout for this issue. If nausea causes fear of eating, it can lead to significant behavioral changes and an entity called avoidant restrictive feeding intake disorder, ARFID. Also, we know there's this relationship between food and emotion and smell and memory. And ginger has ways of sort of relaxing the gut that can help with nausea. So there's actually a whole host of alternative treatments. Acupuncture, by pressing on your wrist, there is an acupuncture point that may decrease nausea and vomiting. And along those lines, there may be nerve stimulators that affect the nerve ending, the vagus nerve, which mediates a lot of the gut sensations, upper gut sensations in nausea and vomiting. I mentioned cognitive behavioral therapy, mindful meditation, and hypnosis are ways of altering the brain in terms of trying to control nausea symptoms by decreasing that or changing that dynamic threshold for nausea. So, in summary, nausea vomiting may be elicited by stimulation of several sites in the brain as well as in the body nervous system. There's many different things that can cause chronic symptoms of nausea and vomiting, including gut motor and sensory disorder issues. Diagnostic testing, such as endoscopy, is important, but also history is very important. And there are a number of medications which are good for nausea, good for vomiting, such as antiemetics and prokinetics. But I think in evolving areas is change of trying to improve the threshold of nausea, and that can be done with neuromodulators. Thank you very much.